Hey, future RN. AV heart block is one of those topics that comes up all the time on the NCLEX, from a simple first degree all the way to a complete block. So today, we're going to break down everything: the ECG features, the causes, and most importantly, the priority actions for each one. Welcome to ClearPath NCLEX, where we make the tough topics easy so you can pass with confidence. Okay, let's dive right in. I know ECGs can feel a little intimidating, but we're going to break this down piece by piece. I promise, by the end of this, you'll be spotting these different AV blocks and knowing exactly what to do. You've totally got this.
So, first things first, what is actually going on inside the heart when we talk about an AV block? Let's start with the absolute basics. At its core, an AV block is really just a communication problem. That electrical signal that tells the ventricles to squeeze, well, it gets delayed, or sometimes completely blocked on its journey from the atria. I want you to think of the AV node as a kind of gatekeeper. Sometimes that gate is just a little slow to open, and sometimes it gets stuck shut. And that's really what the NCLEX wants to see, that you get this fundamental idea.
All right, let's kick things off with the simplest one: first degree AV block. Honestly, this one is less of a block and more of a consistent, predictable little delay.
So the big thing you're looking for on the ECG here is a prolonged PR interval. That means it's longer than 0.20 seconds, which, as you know, is 5 of those tiny little boxes on the ECG paper. But here's the absolute key: it's consistently long. Every single P wave is still followed by a QRS. The signal always gets through. It's just taking its sweet time. So, for your NCLEX questions, if you see a long but totally constant PR interval, your brain should immediately go to first-degree block. It's often caused by meds like beta blockers, or sometimes it's just a normal finding in athletes. So what's your priority action? It's simple. You just monitor the patient. That's it. Okay, moving on to second-degree AV block. Now, this is where things start to get a little more serious. Remember our AV node gatekeeper? Well, now it's starting to slam the gate shut on some of those signals, and that means we're going to start seeing some dropped QRS complexes. So the first type of second degree is called type I, or you might know it as Wenckebach. The classic pattern here, and I want you to remember this, is longer, 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 drop. The PR interval literally gets a little bit longer with each beat, until, bam, a beat is dropped entirely. You'll see a lonely P wave with no QRS after it. Then the whole cycle just starts over again. For Wenckebach, that progressive lengthening is the key phrase. It's often caused by things like an inferior wall MI or maybe some digoxin toxicity. And while it might look a little dramatic on the strip, it's usually pretty benign. So for the NCLEX, your priority is to assess your patient for any symptoms, like maybe some dizziness, but typically you're just going to keep monitoring them closely. And now, for its more dangerous sibling, second-degree type 2, or Mobitz II. This one is very different, and it's much more serious. With Mobitz II, the PR interval is constant. It looks perfectly normal, actually. And then, all of a sudden, with no warning at all, a QRS complex just gets dropped. It's completely unpredictable. And that sudden, unpredictable dropped beat is exactly what makes Mobitz II so concerning. It's pointing to a really serious problem, often some kind of structural damage to the heart. And because it can progress to a complete heart block in a second, your priority action is urgent. You're going to report it immediately and get ready for transcutaneous pacing. This is a huge flashing red light on the NCLEX. Let's put these two head-to-head, because you can bet the NCLEX will ask you to tell them apart. The number one absolute key difference is that PR interval. For Wenckebach, think W for warning. The PR interval gets longer and longer, warning you that a beat is about to drop. For Mobitz II, the PR interval is fixed, and that drop comes out of nowhere. One is usually okay, the other is very dangerous. Okay, deep breath. We've arrived at the big one, the most serious block of them all. Third degree, also known as complete heart block. This isn't just a delay anymore. This is a total, complete breakdown in communication. When you look at an ECG strip of this, it's just chaos. You'll see that the P waves and the QRS complexes are completely divorced from each other. The atria are just firing away at their own regular rate, making P waves, and the ventricles are firing away at their own much slower regular rate, making QRS complexes. They are not talking. They are truly marching to the beat of two completely separate drums. This is a full-blown, life-threatening emergency. The ventricles are beating so incredibly slowly, we're talking often under 40 beats per minute, that cardiac output just plummets. Your patient is almost certainly going to have symptoms like dizziness, confusion, or severe hypotension. Your immediate priority, without hesitation, is to call a rapid response and get those pacer pads on. So you've identified the rhythm. Awesome. That's half the battle. But now for the other half. What the NCLEX really wants to know. What are you going to do about it? Let's nail down our priority nursing actions. No matter what block you even think you see, your first move is always to assess your patient. Check their airway, breathing, circulation. Look for those signs of poor perfusion, like a low blood pressure or any change in their mental status. Then get that ECG to confirm what you're seeing. And if they are unstable, you hit that rapid response button and you prepare to intervene. This is your critical thinking game plan every single time. I want you to think about treatment kind of like climbing a ladder. For patients who have symptoms, we might start with Atropine to give that heart rate a temporary boost. But for the really unstable blocks, like Mobitz II and third degree, the next step up is pacing. Transcutaneous pacing is when we use those external pads on the chest. It's a bridge to get us to a more permanent solution, which for these patients is almost always going to be a permanent pacemaker. And of course, we always have to think about treating whatever caused this in the first place.
You know the NCLEX loves to throw in patient education questions, so let's hit the high points. Your patient has to know to report any symptoms like dizziness or fainting right away. They need to understand their meds and why it's a good idea to avoid changing positions too quickly. And hey, if they end up with a pacemaker, they absolutely need to know the signs that it might not be working right. It's all about safety. Okay, we have covered so much ground. Let's boil it all down to a final rapid-fire review of exactly what you need to know for your exam. This right here, this is your mental cheat sheet. Let's lock it in. First degree, long PR. Just watch them. Second degree, type I, Wenckebach. PR gets longer, then drops. Usually okay. Second degree, type 2, Mobitz II. PR is constant, then drops. That's dangerous. And third degree, P's and Q's don't agree at all. That's an emergency. Okay, time for a pop quiz, NCLEX style. You're looking at a strip, you see regular P waves, regular QRS complexes, but they have absolutely no relationship to each other, and that heart rate is down at 40. What is your priority action? You got it? If you said activate the rapid response system and prepare for transcutaneous pacing, you are 100% correct. That is a classic third degree block. Hey, listen, you have the knowledge, you have the critical thinking skills to absolutely conquer these questions on the NCLEX. Just keep practicing with those ECG strips, keep reviewing these simple rules, and you are going to succeed. And just like that, you've got a really solid handle on EV heart blocks. You are one big step closer to acing that exam and becoming the fantastic nurse you're meant to be. If this was helpful for you, please give it a like and subscribe to ClearPath NCLEX for more simple review content.